like that, right? So we've got a situation, and this is very common. It's like somebody took them like this and went, and that's where they're stuck. But we don't know if that's her true body position. So we just want to gently traction and jostle to see if that is.
Be careful with that ankle on the scar. If you pull that right leg, it'll shoot, that nerve will shoot pain all through that foot if you touch it.
Okay. All right. You've had Achilles surgery?
No, it was the femoral, the artery. I think it's femoral.
Okay. So
I don't have that artery anymore.
All right. So if that's the case, we can't do deep tissue on this leg. All right. Where's the scar?
On the inside of the ankle down.
Right here?
Yes.
Okay. And okay, so they removed part of the artery?
They had to cut and tie it off.
All right. I'm looking for varicosities. Yeah, you don't want any. You don't get deep work done here, do you?
I did.
History of blood clots?
Nope.
Okay. So they didn't give you any like contraindications, nothing, you can receive any kind of body work?
No, the doctors just pretty much said that, you know, it's fine and that it'll compensate for itself.
Okay. Another reason to know really good tissue assessment. So the assessment should feel like part of the treatment. So it's not like you're being real like dry and medical, like, this looks like a short leg and that, you know, is uneven. We want to make it feel good to them because number one, if they're fight or flight, we need them to rest and recharge. You know, we need to get the sympathetic into the parasympathetic. Otherwise, anything you do to them is going to be, you know, very short-lived. So as soon as I start, you know, working on the feet, just doing some general palpation with my thumbs, but of course that feels good. I can tell if they have a high arch, if they have a lot of, you know, residual, like those crystally kind of feelings in their feet. That usually means I've got some metabolites. Here's full water balloon feeling, you guys. Feel her calf muscles. You don't have to push in, but very hard. Just watch when I push in, how it bounces back and kind of jiggles. That's lymphatic congestion, right? Feels like a full water balloon. So depending on her health history, and depending on if there's inflammation, if I feel heat in the area, if she has pain going on, deep tissue would be contraindicated for this particular patient right now, right? If there was pain, especially fatigue, if it was kind of widespread joint issues. Do you have any of that thing going on?
Well, in my sacral and in my shoulders.
Both shoulders?
No, just the right one.
Just the right, so right shoulder, sacral area. So, but keep palpating, but this is she's a perfect model for this particular approach today because this is lymphatic. So if you went to strip out these calves or do some kind of calf stripping, you could back up that lymphatic system and make her more puffy, right, and hurt more. So then I come up here, assessing around the sacrum. And around the sacrum, you have those sacral foramina where the nerves are coming through there and here. So if they have SI joint issues, if you push over that foramina and sink in deep and kind of push and jostle, they'll usually be pretty tender. Is that sore, tender?
Yeah, on the left side.
On the left, okay. So that's some indication, and just by the way this is tilting up and that's rotating downward, you know she's gonna have issues in that sacrum. So if that's the case, doesn't mean it's contraindicated, but I would do some just quick kind of lymphatic kind of pumping, kind of get that. This area is very vascular, so the swelling, the lymphatic congestion will go down pretty quickly. Whereas if it were somewhere else that wasn't like around the ankles, that's not very vascular, around the knees, that's not going to go down as quickly. So
the longer my leg is straight, the more I'm starting to feel it in my adductors and my lumbar.
All right. So that's also a sign that she has compression coming from the lumbar spine. So let's try the bolster. Sometimes that's too much flexion and we just need a flat kind of cheap pillow. But let's try the bolster, see if that doesn't take the pressure off.
Oh, that's better.
Much better? Okay. So basically, do you understand what's happening there? When you're laying flat like this, right? And you have compression of the spine. So if the pain that she's complaining of is sacral and low back related. So when you're laying like this, your low back is being compressed, is pushing on the nerves and causing pain. So that's why when you put the bolster under it, flexes her hip and opens up that L4, L5, S1 compression. So one of the most important things about orthopedic work or working on people in pain is as soon as they tell you you are in pain, you need to get them in a position or use some kind of bolster to get them out of pain, especially if it's referral pain. The longer they lay that way, like if I were to let her stay that way for 5 more minutes, it's going to get worse because that's pressure on the nerve causing referral patterns. So we have to get that pressure off the nerve, number 1. So we know she's got lymphatic congestion. How do we know that?
The gastrocnemius.
But what about it?
It's
It's
jiggly.
bubble like a balloon.
It's like feels like a full water balloon. Then I push on it, it bounces back, and it jiggles. They don't always jiggle, but and it's bilateral. If it was one side, okay, still probably lymphatic, but the fact that it's both sides and she has inflammation, we know that this is a job for lymphatic drainage, probably for one of your detoxification rooms, something like that. But treat the lymphatic system first, nervous system first, get them to that parasympathetic, then the lymphatic system, and then she'll eventually be able to go to like deeper tissue type work. But because this isn't a lymphatic class, I find the easiest way to address this is with cupping. So we can, as long as she doesn't have other like serious signs of a toxic system, inflammatory autoimmune type thing, you can do some quick lymphatic drainage with the cups, move into the orthopedic integrated work, and she'll probably be fine. But if she was feeling pretty sick, I just wouldn't do anything but lymphatic and the, maybe the red light or
So if there was let me just clarify, if there was an autoimmune issue, then you would do full lymphatic. I just want to make sure I'm understanding what you said.
Yes.
Okay.
Mm-hmm. And definitely she needs to be supporting that with one of the tools that you have.
So what you're teaching us not to think like traditional massage therapists.
Clinicians.
You're teaching us to think like clinicians.
Correct.
Because we're doing assessment
Mm-hmm.
and treatment
Mm-hmm.
at the same time.
Mm-hmm.
Okay.
Exactly. Think like clinicians. If all I wanted was a massage, then I could go to any number of places to get a massage with no assessment, but I'm coming here because I want to get well, right? So those are the type of clients that we're focusing on and changing your mindset from a person who does massage to a clinician. You're part of their healthcare team, basically. So then once I get up here, and I'm doing all this through the sheet, by the way, and it's very relaxing, and I'm breathing, and now I'm assessing the spaces in between the transverse processes, right? So that little lamina groove that runs up the spine, and I'm feeling where those speed bumps are. I start to feel right around that thoracic area. You can feel where those transverse processes are kind of sticking up there, which is also something that we will help with the alignment or mobilization of. We're not doing high velocity, obviously chiropractic, but we can help with the alignment there. And then I feel the neck, kind of give her a little, my Aunt Jane used to call this the kitty cat. She really likes that. Huh? Goosebumps. And then I'm coming over to this side, so I'm on the opposite side of the spine, kind of scooping out that laminar groove.
Whenever you pushed on it down close to the sacrum, I felt it resonate to the top of the back, to the front of the hip.
Okay, that's good information. So, people with sacroiliac dysfunction that look like this, common issues you'll see is when you palpate and do the assessment, they'll feel it in different places. They might feel, when I push here, she might feel it down here. I mean, they usually feel it in different places. Some feel it up in their shoulder. Another telltale sign is they feel it when they turn over. So when they're trying to turn over, like, oh, that hurts me, that's because this is off. I mean, this is a classic textbook example of sacroiliac dysfunction and L4 to S1 compression. She's got every sign of it.
So question, if she was a normal client and we weren't in class, when you noticed the hip raised, when you noticed the way she was laying in the four, do you communicate that? I'm noticing your...
Yes. So that's a really good question. From the get-go, you need, when they're sitting in the chair, like, why are you here today? Are we here because you want a massage? Bend over a little bit, flex of the spine. I want you to take your right ilium and rotate it down to the floor. Feel how this sit bone goes up, right? It goes up here, this one goes here. That's what's going on with her body. It hurts your back, doesn't it?
Mm-hmm.
So that's what we have going on here. Do you still have that pain going down your leg?
Yeah, it's in my ankle.
In your ankle? Then we need to change your position. So this is where you have to pivot, because the bolster is not working. It's still going down to her ankle. I want you to lift up your, we need a flat pillow. Do you have a flat, thin pillow? Underneath her as is, like this. And it's only flexing the lower part of the spine. It's not flexing up here. You see how lordotic she is, right? So that's exaggerated lordotic curve. So we need to help straighten that out to get that pain to go down a little bit. This might work. And if it doesn't, I'm gonna let her body relax into this for a couple minutes, and if it doesn't, then we have to flip her either on her back or on her side, wherever she doesn't feel that radiculopathy. Radiculopathy is radiating pain in the extremity.
Oh, I wouldn't do it on my back.
Okay, then you'd have to do it from her sideline position. That's why, another reason, the assessment's important. I've had massages before when I had SI joint dysfunction where they laid me face down for like 20-30 minutes, and then I could barely walk. So whenever there's radiating pain, any pain, don't leave them in that position. Get them whatever position. You might spend the first 5 or 10 minutes just finding the right position. But once you've done this for a while and you know the anatomy, you could do it from a seated position. Literally hang them from a chandelier and do it if you know the anatomy. How's it doing now?
It's not my ankle anymore, but it's definitely my femur.
In your fingers?
Femur.
Like the front of the femur?
Side, like
Okay.
IT band area.
All right, so one of the things you can do, and she says this ankle is sensitive down here.
No, this one.
All right.
It's the right one.
Okay,
The
so
left one's fine.
one of the things you can do that will usually give immediate relief is traction. So instead of grabbing her ankles, and I'll tell you why I'm not going to in a second, I'm going to grab up above, and then I'm just gently traction and hold it, and tell me if that gets worse, better, or stays the same.
That's better.
So just hold it. We're taking the pressure off of the nerve. It's called traction, manual traction. Decompression is another word for it. In our business, there's many, many words to describe the same thing. So after a while, you'll learn what they mean. And then just a little bit of jostling. Jostling is very calming to the nervous system. It's also called the Traeger technique, Trager. Morton Traeger is very famous for this
I remember that from school.
Traeger therapy. So what am I doing by tractioning?
Activating the nerve.
Releasing pressure off the nerves
From where?
into the sacroiliac.
So you're decompressing the lumbar and sacral area. Yeah. Mostly, they'll feel it where they need it, but mostly we're targeting 4, 5, S1. And we're also decompressing the hip joint, the knee. And then when you release it very slowly. If you release it too fast, then it pulls back and pushes on the nerve. Right? And then check in with them. Is that pain better, worse, or the same?
Yeah, it's back to just being in the hip.
Just into the hip? Okay.
Or not, yeah, well, a little bit in the hip, but also in the
Okay.
sacral and
Now,
the-
second thing, it's going down this side, right? Going down into the hip, correct? You know this is off, so make it look good. What happens if I slowly decompress L4, L5?
That's so much better.
So much better. Hang out here. Do some gentle, it's called mobilization, sacral modes. Do you have, somebody have a question?
Yeah, I was just gonna mention, like, I haven't really had any encounters with people who have like really, really chronic pain, but when they do, I'm not sure, like, should I just move on with the process, or?
Assess their
Recommend.
tissue, look at their health history. If they have inflammation, do you know what inflammation feels like?
Yeah, it
Okay.
was pretty fluffy,
And
really bouncy.
warm, or sometimes hot. Like if they're saying I have pain in the shoulder, I would feel both shoulders at the same time on their skin. So it really depends on your assessment, and your assessment is just important as anybody's. Because again, whether they're hypermobile, they're hypomobile, they're inflamed. If I have bursitis in my shoulder and you stretch my shoulder, it can make it a lot worse. So your assessment is just important as anybody else's. And that's based on health history, range of motion, orthopedic testing. That's what we're here for. Alright, so I just felt it release. You see how my hand kind of went down like that? Alright, then give it a break. Sometimes if it's been compressed for a long time, it may not be immediate because that inflammation in the disc is probably still swollen, but the more that we can get her sacrum straight, the less pressure is going to be here. Okay. What's that?
So, I'm kind of putting back on one hat. Does this even feel like treatment to y'all? I mean, because it's different than what you're used to. But you don't have to be flushing through the body because that's traditional massage. This is treatment that's changing your life. Does that make sense?
I actually do this move a lot with people who have they tell me their lower back hurts. What she's doing is something that I do a lot.
It's called sacral mobilization.
Of course, I'll do it from up top, and I'll put my hands in either like dimple and just gradually push down and hold it.
Yeah, so we're isolating the side that the compression is on. And if I were to hold both sides equally, what's going to happen? I'm going to make it worse.
Make it worse.
Because I'm going to push that side down, and this side is going to come up more. So the side that is elevated, I'm trying to get that down. So this goes from general to specific. Specifically think, what should they look like? It should look something like that. What does she look like? This and that. So if I just come up here and I push down like that, will it feel good? Maybe. But then when I let go, now this one is more down here, this one's more up here, and there's rotation. So make them look good. You're gonna work both sides, but this is where the assessment comes in, is you don't know, even because the pain might be here, maybe that this QL is locking down here, this iliacus. So that's why we assess both sides. They'll get into each muscle. If there's no tightness, there's no trigger points, there's no lymphatic congestion, move on to something else. Something else needs your attention. If it ain't broke, don't fix it. Right? If the tissue is tender, if the lymphatic system is congested, that's what we need to be. Okay, so that's basically the beginning of the assessment. We also want to do some range of motion testing. Again, when we're doing the integrated approach, they have their underwear or not, doesn't really matter. You know, you tuck how you tuck, however they're most, feel most secure. Then I'm going to test that range of motion. So, knee flexion, internal rotation, external rotation, they feel pretty smooth. There's no like choppiness or pain with that movement. There's not excessive range of motion. If I can bring, like this is 0 degrees, if I can go beyond 45 degrees and their foot's pointing out here, that's excessive range of motion. Do not stretch those people, you're gonna hurt them, right? And then if I go internal rotation, this is 0. Internally, they should have about 20 to 35 degrees of range of motion. She's good there. Any pinch, pull, or pain when I do this?
On the opposite side, and so
What did I say about people with sacroiliac dysfunction? They'll usually feel, when you're testing, they'll feel it on the opposite side. That's normal, right? I test range of motion in the ankle, how much inversion, eversion, flexion, plantar flexion and dorsiflexion they have. Right now, I'm not concerned that you know the degrees. Don't get all muddled up in your brain about degrees of range of motion. I would rather you think more about what's the end feel. Like a healthy end feel of a joint, when that stretch reflex kicks in, you should feel like it's soft and leathery, like a leather belt. Doesn't stretch very much. It has a distinct stopping point. If you're like, keep going, keep going, keep going, hypermobile, don't stretch them. You'll destabilize a person in pain if you do that. So if it's an empty end feel and you're like, when does this thing ever end? That's hypermobility. If it's a very distinct, like bone on bone end feel, that's hypomobility. So you're like, boom, that's the end of it. You can't go any further. Don't stretch them beyond that, because then you're going to injure them. So once I feel that, I'm like, okay, she's got limited range of motion in external rotation. I'm making note of that, but hers is good. She's got normal end feel here. See how it's kind of soft and leathery. I'll go to external rotation, normal end feel there, soft and leathery. Flexion is okay. I'm not going to push it past there because she's got the swelling here and swelling here. I feel that bounce back, lymphatic. Okay, then I go plantar flexion, plantar, dorsi, inversion, eversion. Again, I'm not really concerned right now that you know this should be 20 to 35 degrees of range of motion. I just want you to know that in this position, it should stop about there with a soft and leathery, it's hard to say, but it keeps going, right? So she's got hypermobility and inversion, which if you have hypermobility in your ankles, inversion or eversion, what's that going to cause? Sprained ankles, instability. So what came first? The chicken or the egg? It's good to know the patterns, but once you have hypermobility in the foundation here, then you're always gonna be trying to stabilizing up the chain. So really for her, lymphatic drainage first. This would be what I'm thinking through in my mind. Lymphatic drainage first. And when we flip her over, we're gonna check the abdominals too, see if around the inguinal nodes and around the axillary to see if there's other lymphatic issues. But I would do lymphatic, some of the detox program machines, and then to later on get into the orthopedics. But if you wanted to, and you feel really confident working with people with radiating pain, you could do the orthopedic work, but don't do it before the lymphatic because you're going to make them worse. And if she just, for now, wants the integrated massage, you've gotta find a better position. 'Cause see how she just did the figure 4? So this is not gonna work for a starting point as far as the massage goes, alright?
So what if she came in just for, like, I want a regular, we call it relaxation, but a regular Swedish massage. If my client came in like that, and that's what she wanted, but was noticing some of it, I mean, how, do you just go on and do the massage, or?
Well, first you gotta find a comfortable position, and if what I'm hearing you're asking is, she's got this pain, but she just wants a regular massage, would I go ahead and do it? Yes, but no stretching, and no deep work. Because you don't know yet, she could have a bulging or herniated disc. So what I would do, if she came in for a regular massage, I'd say, all right, well, we need to find you a comfortable position. So I would start putting another bolster. Actually, I put the bolster under this hip to find the comfortable position, and if that doesn't work, then we would, once we get that established, I'm gonna do kind of a relaxation massage, which will help with the pain, because it helps with the nervous system. But then, next time you come in, we need to, we'll start with some more testing. The straight leg test we did last time, the Thomas test, the Faber test, all of those I would do, but you don't need to do it now. She's already undressed. You're already, we just know why we're here right now is we're just here to calm the nervous system. And then see whomever at the front, because this is a product of some inflammation in your body. See them at the front to know which of the tools you need to use here. And then we can schedule, I would say schedule more of a clinical, or what do you say, more of an orthopedic treatment.
We refer to it as medical.
Okay, medical. So next time, today we're focusing on nervous system. Let's just, calm the nervous system, then work on the inflammation. Then next time you come in,
We would do
schedule
lymphatic
for a medical.
and then go from there.
Yeah. I would lump lymphatic under the medical too. Like anything but Swedish is all medical.
Yeah.
Okay. Does that make sense?
Yes.
All right. So when you guys get on the table, we're going to start face down like this. If you have back pain, or you have pain like she does, go ahead and grab yourself one of those pillows, or if you know that bolster works, then use the bolster. But then we'll start with the prone assessment, and that's assessing the tissue, any lymphatic issues. That's the the sit bone, ischial tuberosity, sacral foramina, and then the lamina groove and transverse processes. And we'll play the video, so you just follow along. It's going to feel like it's going fast for some of you, but that's just the nature of it. And then you can watch the videos and practice on each other and things like that. Sound good? She doesn't have radiating pains. So always have, even a rolled up towel would have worked. Just now see how much more even she is than before.
Yeah, it even it's not high like it was.
Right. Before, it was the left side ilium was tilted like this, so you had a right rotation, and then the sacrum was tilted up like that. So it was a torque. Even out the torquing in her pelvis.
And when we're doing decompression, you're just wanting to be patient, so you can feel when the tissue releases. Just holding, steady pressure.
Yeah, steady
'Cause I can
pressure.
feel it slowly.
Yeah. So sacral lobes. Decompression is sort of the same thing, but actually that's more like traction, or what you're doing is called a sacral mob.
They use the wrong word.
Yeah,
yes.
sacral mobilization. Yeah.
Okay.
Okay, so just working on the terminology too, because there's so many different word soups in our business. Alright, so tissue density first.